easels, WOC, IOA, ASSI, and many more. He is one of the few from India to have delivered the prestigious Hunterian Professor Oration in 2011-12 at Royal College of Surgeons, England. He has been a distinguished visitor to Harvard Medical International, Boston. He has done phenomenal contribution to literature and research. He has more than 200 international publications, 48 national publications. He has given more than 500 national and international presentations. He has written more than 60 chapters in international books. He has been editor to multiple national and international journals and received many national and international awards. He has received International Easels Research Award on 4 occasions, which is more than anyone has received in the world. He is probably the most cited Indian orthopedic and spine surgeon. He was instrumental in evolution of Ganga Hospital Orthopedic Injury Severity Score, which helps us in taking critical decisions in saving and reconstructing severely injured limbs. We are very lucky that Sir has agreed to spare his precious time today to interact with us. So without wasting any more minute, I hand over to Professor S. Rajshekharan, sir. Sir.
Thank you, Akshay, and thanks to all of you for this great privilege. So I have been to Indore more than twice, and every time it has always been a great pleasure to meet all of you. And thanks, Akshay, for this introduction. So I'm glad that things are going on very well in Indore, that your academic spirit is flying very high, even in these times of pandemic blues. So we all thought that we have crossed the border. We are at the end of the tunnel, and sadly, the second bout has also come. But I think this is sometimes good because it has really made us introspect quite a lot. And whether you are an individual or whether you are an institution, I think in our institution, we did a lot of introspection during this period, and it helped us to look at where are our strengths, where is our weaknesses, and this time has given us the possibility to get into better things. If everything is going good all the time, it doesn't work out very well. One thing that we learned is that the person that one is mattered more than the virus, because we saw people buckle down, we saw people coming out very strong, and COVID threw the same challenges to everyone, but individuals responded differently and came out of it very differently. So we don't have a choice of whether there is a second wave or a third wave, but I would request all of us that we should look at us internally and come out very strong. We can either complain or we can adapt, or we can fall into and reinvent a new model for ourselves and our institution, so that at the end of the time, when the tunnel ends, we will all come out very, very stronger. So today, as you know, Tamil Nadu has gone into a lockdown. I'm sure that the national lockdown also will come, but a personal lockdown is an individual option. So maybe our clinical work will come down, but this is a gift of time when we have a lot of time outside our profession, and we should really be sure that we don't die before we are dead, and we learn quite a lot. So I really congratulate the Indore Orthopedic Society for keeping up the academic flag high and keeping up all the activities going on, and congratulations to all of you. Now, I was told to talk something on trauma, and I thought it will be more relevant if I talk about something which we were closely involved with. Trauma has a special challenge worldwide, and these kinds of injuries are very, very common, especially in India, where one person dies on the Indian roads every 3 minutes. And for every person who is dead, there are at least such massive injuries. Now, what is good is that in these times, you will find that if you do the correct kind of treatment, even these injuries can be restored back to normal, and you can get a reasonably good limb. Now, this is another example. It's not just in the upper limb, but also in the lower limb. You can find that this is a bilateral injury. Patient also has an ARDS, which is a really big problem. And in spite of this, if you follow the sequence of events, you will find that you get a very good result. You can restore these limbs. The patient can get back to normal life. You can see that this was done many years ago. He is now happily married. He has another child also. So all these are really good if you follow the principles. But the main issue is that this is not the exact outcome every single time. If you look at the world literature and you have a patient like this, you will find that 5 to 27% of them have a primary amputation. Up to 1/5 of these patients enter into a major complication, an irreversible complication, an irretrievable problem that ends up in a secondary amputation. Or another 1/5 get into a problem. They have a salvage of the limb, but the results are so bad that the patient is deeply unhappy about it. So what is important is that when you get an injury like this, we really have to know that we are already on a sliding scale, and 30% of these people are going to end up with a major problem if you're not very careful. Now, the idea of the open injury score exactly was that there are 3 outcomes that are possible when you have a major injury. Now, this is the best. You debride, you do attempts at reconstruction, you do a successful salvage, and that's excellent. That's what all of us want. The other one is that you debride, and at the end of debridement on day 1, you decide that it is non-salvageable and you do a primary amputation. That is not the best, but still it is acceptable. But what is not really acceptable is that you attempt to salvage. There are multiple attempts at reconstruction. There are lots of complications. Secondary amputation occurs. And at the end of many surgical procedures, a lot of onslaught on the psyche of the patient and the family members. And then the patient loses the limb. That is not acceptable. Now, when our trauma rates were growing up, and we were almost hitting at 500 3B injuries every year, we found that this was the most difficult decision on how to decide between amputation and this, and how to counsel the patient and convince the patient that he required an amputation. And that was the reason why we came up with this solution. Now, Gustello's classification is a very important milestone, but since then, a lot of water has flown down the bridge. There are microvascular reconstructions, there are bone transport facilities possible. There is a lot of change in concept. And then we found that Gustello's classification is not sufficient. Why? The primary reason is this. Under the basket of grade 3B injury, we find the good, the bad, the ugly, and the rotten all put into the same basket. Now, you will know that by definition, all these are 3B injuries. But you have the easily salvageable to the barely salvageable all packed into the same basket. Now, the treatment principle and outcome is the same for this whole group. That's a major problem. Gustello's classification itself, by definition, has undergone many changes, many different changes. So there is a poor inter and intra-observer agreement, and these 2 publications have clearly showed that the average agreement was only 60%, and some injuries are inherently difficult to classify with many wide variations. Thirdly, there is a problem with the definition itself. Now, this all of us would agree, it is 3B. But if you go to North America, that definition of a 3B injury is an injury which needs a soft tissue reconstruction. So if this injury has been treated by a primary closure, then what was a 3B injury at presentation, after treatment becomes a 3A injury. Now, this is not what is the purpose of a classification. A classification must guide treatment, and it should not get modified by the treatment that you have given. So the 4th problem with Gustello 3B, it's largely wound size based and not tissue injury based. And this is very difficult to follow. I will just tell it with an example. What is the importance of wound versus tissue? Now, you'll all agree that this looks very ghastly. It's really a very bad injury because the soft tissue injury is so huge, but the bony injury that this patient had was a patella fracture. Now, this is completely different from this injury, where the soft tissue injury and the wound is very small, but there is a huge comminution for the whole of the bone. So, here the bone is the problem. Whereas in many of these injuries, there is a combined complex injury where every tissue is involved. So Gustello's does not classify or differentiate or does not uh, look at the severity of injury of different tissues in the limb, and that is a problem. Now, there are other predictive scores which have come between Gustello's and the Ganga Hospital score, like the MES, the LSI, PSI, NISA, and all this. But they all have one single major problem, that these scores are designed to assess ischemic limbs with combined orthopedic and vascular injuries. So if you do not have a vascular injury and if you have a very bad 3B injury, now all these scores will underweight these, and you may be tempted to salvage this and end up with the mess of having a secondary amputation. So none of these were oriented specifically for 3B injuries. They were all for 3C injuries. And we know that for every one single 3C injury we see, there are at least 10 3B injuries. And that was the reason why we thought that we should have a specific score which is looking at Gustello 3A and 3B injuries and not at a 3C injury. Now, the principle of the score is very simple. Now, we have three major tissues in any injured limb. Now, the first is the skin and covering tissue. That is assessed separately. Then there is the bone and structural tissue, joints, that is assessed separately. Then the third is the functional tissue, which consists of the muscles, tendons, and nerves, and that is assessed separately. Now, each of these three tissues are graded from 1 to 5, depending upon the severity. And to this, and this is a really big improvement on the Gustello scores or any other score, we also added the comorbidity score. Now, because we know that any one of these injuries is a completely different kettle of fish if we have to operate on a young, energetic, healthy college student compared to somebody who has also had a head injury, a 70-year-old man, and then the treatment options and your decisions are completely altered. So we added comorbidities also to it. Now, the score for the tissues were given from 1 to 5, which were 1 and 2 required no special skills or no special procedures. 3 required special skills, but required still you can get a good result. 4 and 5 were severe injuries which demanded special skills. I'll just show you an example. The skin was from 1 to 5. Now we know that if there is a loss of skin, that is an important factor. And if it exposed bone and it was over the fracture site, that was also an important factor. So skin which did not expose the bone was 1 if there was no loss, 2 if there was a loss. If there was a tissue loss, that means you required a flap. Then if it was not exposing the bone, it was 3. And then if it was exposing the bone, it was 4. And the circumferential injury was 5. Now we'll know that each of these requires a graded increased severe complexity of management. Now this is also very well understood in the bone score. Transverse fracture was 1. A large comminution of more than 50% was 2. Comminuted or segmental fractures were 3. And bone loss of less than 4 centimeters was 4. And more than 4 centimeters was 5. Now if you look at the logic of how this 1 to 5 came. Now this could be treated as any closed injury. You can either plate it or you can use an intramedullary nail just as a closed fracture depending upon what you want. Now if there was a comminuted fracture and this was more than 50%, sometimes it will require a removal of this fragment and then some bone grafting is required. Of course, segmental fractures and comminuted fractures is a different kettle of fish. If you have a bone loss of less than 4 centimeters, then most probably it could be treated with a masculine technique or bone grafting technique. Whereas if it crosses 4 centimeters, you either require a free fibular graft or a bone transport. So you can see that the complexity of management keeps on increasing, and that's the basis in which we have given the score. Now, functional tissues, I would actually request you to read the original article. Now, score 1 is musculotendinous units exposed but not damaged. 2 is damaged but repairable. 3 is partial loss of a compartment and including an injury to the posterior tibial nerve. A full loss of a compartment or multiple compartment injuries were 5. We have given a very good example and of logic of why this is happening. Now, if you find it difficult to exactly remember how to score, the Ganga Hospital Open Injury Score is now available on Google Play Store. It's a freely downloadable app. And if you go into the score app and you can download, it will allow you to go step by step to score each of these tissues and the comorbidities, and it will also give you a score and also give you a recommendation of what it is. So this can be downloaded over there. Now, on the comorbid scale, we added 7 comorbidities, which we thought and which we knew actually influences your decision on how to manage. Late presentation, severe contamination, elderly age, debilitating comorbidities, fat embolism, coagulopathy, systemic injuries, and another major injury to the same limb. All of this influences the outcome and also influences on how you are going to manage. And so each of these were given 2 points. Now, all of these added together gave you the total score. Now, in the first series that we published in the JBJS, we found that when you had a score of 13, every single injury was salvaged. Now, when you had 14, then the sensitivity became less. As you went down, you will find that the number of persons that whom you can salvage was becoming less. So 14 and below, everybody well salvaged. 17 and above, everybody, 18 and above, everybody were, had to have an amputation. And there were 3 scores, 15, 16, and 17, which was the gray zone. So we all said that if you have a score of less than 14 and below, you should try to salvage it. But if you have a score of 17 and above, be careful because it needs, the chances of it requiring an amputation is very high. We didn't say amputate, we only said please consider a lot before you will try to salvage these because the chances of success is very, very less. Now, beyond that, this score has been tested multiple times. And this was redone recently on 227 patients. And you will find that if you have a score of 13, every single patient was salvaged. Now at 14, it fell down to 80%. 15, the salvage rate fell down to 50%. 16, it was 14.2%. And at 17, it was 28%. And 18, 0%. So these two end points still hold good in many times that we have tested and in other publications also. 13 and below, you have a very good rate. 18 and above, you have a very poor rate. So in between, in these, you know that your success rate is rapidly falling down, and that we call as the gray zone. Now, approximately 12% of grade 3B injuries fall within this gray zone. So the score is really good to predict on 85%, but in 12%, you have to be really careful what is a gray zone. So when we published in the JBJS and I wrote that this is a gray zone, the score editor objected very severely to it, and he said that a score cannot have a gray zone. And so we had to have multiple communications with them because in something as complex as an open injury, then a lot depends upon the infrastructure, cost provided, skill of the team, and patient factor and cultural factors. And we had to explain them with many examples, and then the JBJ is accepted for a gray zone. Now, this is two different examples I'll show to explain. Now, this is a 23-year-old male who has multiple injury. Now, the lower limb can be amputated if there wasn't a problem like this in the upper limb. Now you can see there is a major problem, an avulsion injury, and this patient had a total brachial plexus injury. Now, if you do an above knee amputation in a person and he has got a flail upper limb, it becomes such a big problem for him to even wear a prosthesis. And so you can see here we went on to an extended salvage, and then you will find that even though he has got a flail limb, but flail upper limb, you can find that actually it allows him to move. But if you have amputated him with a brachial plexus injury, he cannot manage. For the same score, you will find that we amputated in a 71-year-old male, mainly because that he had a myocardial infarction 3 months before. And this gentleman is not going to, it's too risky to do multiple surgeries and flaps and other things on him. So we showed many examples like this on the gray zone and said that within the score of 15 and 16, you have to decide on a case-to-case basis, and this was accepted. And what was initially thought to be a disadvantage actually is now talked about as the strong point. In the last year, American Academy, when there was a discussion of all the scores, they actually said one of the highlights of the Ganga Hospital score, unlike the other scores, it actually does not give a cutoff point, but it gives a gray zone in between, which is actually natural logic of how you treat a patient. Now, although the first publication was only about deciding on the salvage, now we have facility to know that it helps in many other ways also. Now, when you have a major injury, the first thing that the patient or the patient's relatives ask, or how many days the patient will have to stay in the hospital, the number of surgeries that you will have to go, and what is the approximate cost. And in subsequent many studies we have done, we found that the score actually corresponds well to answer all these questions. Now, previously it had to be guesswork, but now you can actually, on a scientific basis, tell what is necessary. Here you find that when the score is less than 9, in 67 patients, the average number of surgeries that was required was only 2.5. Between 10 and 13, the surgeries required was 2.9. When the score was 14, 3.8 surgeries were required. 15 and 16, it became 5.1. And when the surgery was 17, you find that 11 procedures were required over here. So you will know that, looking at it, that whenever you have a score of more than 14, you have to confidently tell the patient that approximately 6 or more surgeries or surgical procedures are required to salvage the limb, and the patient has to understand. And if you are able to counsel him on a scientific basis, then it becomes very easy for you to do this. Now, we last year, before the COVID year, we treated 823 3B severe injuries. Usually, we don't have a great problem in the follow-up and in counseling, because we photograph the patient, we put the score, and then we, on a very scientific basis, we tell them this is going to happen to you over the next 1 year. Then they fully understand what is happening. But more important than the cost or the number of days that they have to stay in the hospital or the number of surgeries that they have to do, what is very important to the treating surgeon is also it provides guidelines on how to treat the patient. Now, this is completely, again, unique and not present in any of the scores which are available on the this thing. Now, when you get an injury like this, we follow the same pathway worldwide. We resuscitate, we debride, we do skeletal stabilization, we do the soft tissue cover, and mostly then the definitive bony cover. Very rarely, in less than 12%, you can do both of these together. Now, worldwide, all these three are done on day one. Resuscitation, debridement, and skeletal stabilization is done on presentation. But soft tissue cover and definitive bony procedures are done after some time. Now, there is a concept. Can you do a global reconstruction? Can you do a total day one reconstruction? Not that it is not possible or not, but whether it is safe or not. Which are the patients where you can skip these stages and go on to a total reconstruction? What are all the procedures that are possible to be done on day one? Now, that was the reason, that was one of the publications we wrote from injury. They asked us to write an invited editorial, and we wrote on the philosophy of the CAD. Now, in this, on an analysis of 540 cases of 3B injuries, we found that these are the possibilities that you can do. You fix the bone either by an external fixator or stabilize it in any way, and then you can close the wound. You can fix bone graft and close on day one, fix and skin graft, fix and early flap. Or, as normally done elsewhere in most of the institutions, you fix, wait, and reconstruct. So these are the 5 possibilities that you can actually do. Now, how do you determine which are the cases which are ready for closure or flap? And even if you are doing a skin grafting or flap, is it safe to do it on day one, or do you have to wait and do? These are the 2 questions. The 2 questions are suitability of closure or the requirement of a flap, and you also do whether you can do it early or late. For that, in the score, you have 2 important guidelines. One is the skin score, which actually tells you the suitability of closure, and the other is the total score, which is the sum of the, gives you an indication of the energy of violence, and that decides whether you can do reconstructive procedures on day one or you have to wait. Now, I'll tell a good example here. Now, these are large injuries, but you can see the difference between here and here. This scores a total of 7, whereas this scores a total of 10. Now, we have found whenever your total score exceeds 9, then the energy of violence is very high. These limbs undergo a lot of edema on the next day. You cannot assess the zone of violence very accurately on day one. And whenever the score exceeds more than 9, you have to stage your reconstructive procedures. Now, this again was tried and tested again, and you can find that in the timing of surgery, whenever there is a score of 9 or less, we found that in 88% of patients, we were able to do early flaps. But when it became 10 or more, in 64% of patients, we had to stage. Now, what is the speciality of the score that allows you to do this? Now, unlike Gastilo's score, which is obsessed with the size of the wound, in Ganga's score, the skin score does not matter on the size. It only matters on whether there is a skin loss or not, and whether it is on the fracture or not on the fracture. So whenever you have no skin loss, however big is the size of the wound, it will still score only 1 if it is not over the fracture, and it will score 2 if it is exposing the fracture. And if there is a skin loss, which means that either during the injury or during the debridement, you have a skin loss, and then you are not able to oppose the skin, bleeding margins of skin without any tension, then it gets a score of 3, however small the wound is. 3 if it is not over the fracture, and 4 if it is over the fracture. And of course, circumferential wound with skin loss is 5. Now, how it influences the treatment, this is a good example. Now, here is a fracture. Now, this is no skin loss, and it is exposing the fracture site. So it is 2. The bone is a transverse fracture. So it is 1. No muscles are exposed but not severely damaged, 1. No comorbid factors. So the total score is only 4, which means that the energy of violence is less, and this patient can have a yearly reconstruction. So this, you can see that the patient was treated by debridement, interlocking nail, and primary suture, and she went on to a very good result. Now, to push home the point to say that we are not looking at the size of the wound, but actually whether there is a skin loss, this is the second case where you can see that this is a much larger injury than the previous injury, but still you will get only a skin score of 2 because this is a big laceration, but there is no skin loss. Now, once you have done this debridement and you have done this and you have fixed it, you can find that you are primarily able to close, and so the total score is only 4. So it was possible for you to do a early or immediate closure, which is a bigger one. So what matters is that whether there is a skin loss or not, and not whether there is a this thing. So in contrast to this, you will find that this patient has got a wound which is smaller than what we saw in the second case, but it has a high skin score of 4 because you can see that there is an actual loss. When you have an actual loss, then it is important that the total score is becoming 7, but still it is less than 7. So skin score is high, so it needs a flap. Total score is less than 9, so it can be done early. So you'll find that these patients have a quick early flap. So you can fix and you can do this flap either on the same day or you can do this flap within the 72 hours. Another example, you can see that this patient also has been fixed and has had a flap immediately because the total score is less than 8. In these multiple examples, you can see over here that whenever you have large gaps also, but your score is 9 or less, then these patients are amenable to a very early flap. What is the big advantage? Because as you keep these wounds open in the hospital, these patients get infected because we now know that most of the time that these injuries are infected with MRSA or multi-drug resistant Pseudomonas or Klebsiella or E. coli, not from the injured site, but from the hospital. So the earlier you close, it is very good. And then you will have to check whether there is a suitability. In contrast, if you have injuries like this, where the score is more than 11, that means the energy of violence is very high, and it will be too risky to do any reconstructive procedures on day 1. So here you should follow the pathway of safety. You do a good debridement, and then you fix it with an external fixator, and at a later stage, you convert it into interlocking nail or a plate or whatever you want, and then you do a flap, and then you get success. Another example, a massive injury like this, you will see that the total score is 14. No place for any kind of reconstruction immediately. You will have to do an external fixator, then convert it into a orthofix where you are doing a bone transport, and then do a free flap, and then you can find that these patients undergo safety. So overall, for the question, whether there could be a score that will help in assessment of severity of injury to the individual tissues and also to the whole limb, which will give separate weightage to comorbidities of the patient, which will influence your decisions, which will reliably predict salvage, guidelines for timing of reconstruction and type of reconstruction, and also predict outcome. To all these, the Ganga Hospital score actually lends itself to use. So slowly this score has found its way into international usage. It's very widely used in most of the countries in South Asia, Africa, and it's also published in almost all the important textbooks on trauma. And in Rockwood and Green, also on day 1 reconstruction, and this thing they have recommended that we should follow this score. And quite next week, there is a big multi-central trial which is taking up the score against all the other scores in the University of Cambridge. So internationally now, it is being widely followed, and this is the basis actually of how the score slowly evolved. It was initially evolved for salvage, but over a period of time, it has found many other different uses also. So thank you very much for this opportunity. If there are any questions on this, I'd be too happy to answer this or anything, whatever you want to discuss, that will be fine. So thank you, Akshay. Thank you to your president, secretary, and all the members for giving me this opportunity to connect with all of you during this period.
Thank you, sir. Thank you very much for such an illustrative and descriptive talk. It's always a pleasure to listen to you anytime, any day. So the house is open for questions. We have one Dr. Beth, sir. You can directly ask a question, please. You have put in the chat. You can unmute yourself and ask the question to sir directly. You have to unmute yourself. Manoj, sir, you have to unmute yourself.
There is a question which I can see from Dr. Manoj Bait.
Yes, sir.
Do you consider age also in comorbidity section? Yeah. So if you see our comorbid status, we have put an age above the age of 65. So it is. So if you see age, there is a chronological age and a biological age, but you don't go very strictly about that. But a lot of people who are above the age of 65 have other comorbidities also. So nowadays you find that the number of people, we were taking a survey last year, the number of people on blood thinners above the age of 65 is now increasing steadily every year. Neurologists and cardiologists put almost everybody on blood thinners. So the number of people having cardiac kidney diseases above the age of 65 also is on the increase. So that is why we put an age of 65, we gave a score of 2. So that is one of the comorbidities considered. There is another question from Dr. Anil Magajan. What is your opinion about primary flap and Elizaro ring fixator in score 10 or more? Yeah. So the decision to do a flap or not and to do a primary flap is decided by the score of 10. So score of 10 is actually at the threshold. So we say a score of 9 or below is better. So when it grows above 9, with each increase in score, the extent of violence or the energy of violence absorbed increases exponentially. So let us look at it in a different way. When can a patient get a score of 10? So they can get a score of 10 only when, at least in many of these subcategories, their score is more than 3, isn't it? So that means they are having a severe injury to the skin, they are having a severe injury not just to the skin alone, but to the musculotendinous tissue and to the bone also, or there are at least more than 3 comorbidities. So which means these patients are at high risk when you reach a score of 10. You still can do it because it is just at the highest level of cutoff mark, but you have to be careful. Elizaro ring fixator, we have slowly come out of it because of its multiple problems of ease of doing a flap within an Elizaro fixator. But if you're very good in Elizaro, there is no problem in doing an Elizaro and a flap. Absolutely, there is no problem at all. Okay, what would request everyone their videos? Have you found tobacco consumption anyway to affect overall outcome? We have not done a study on this, but whether you smoke tobacco or chew tobacco or whatever form of tobacco you have, the end product is increased nicotine in the body. And nicotine users, there is enough amount of literature to document that they are highly susceptible for infection. They are highly more susceptible for failures of soft tissue reconstruction, microvascular anastomosis failure. And so if you have a tobacco chewer chronically or at a high level, or smoking or chewing, then they are definitely at a high risk for complications. Now, it's also important for you to document this in the case sheet and get it in the consent form itself. So, if you have a complication, you always have the fallback of saying, okay, this was been already discussed before itself. And during all your follow-ups, you should make a particular inquiry, have you stopped smoking? Don't ask the patient, they will always say yes. So even before you have to catch him unawares by asking the wife or the daughter or the son who comes and asks, has he stopped smoking? And if they say no, he has not stopped smoking, you document it in your notes, patient has not stopped smoking, because it will help you a lot to whatever kind of complication you have, you can always associate it with smoking, and there is medical proof for that also. So tobacco consumption is really bad. What is the criteria to stop debridement? I'm not fully understanding that question. What does it mean? How extensively do you debride? Is that the question?
Yes, sir. Dr. Negi sir, you can unmute and clarify.
Alok Jain sir has asked this question.
Okay.
Dr. Alok Jain has asked. So, what is the criteria to stop?
Can you hear me, sir? Good evening.
I can hear you very well.
Yeah. The thing is, I have seen the wounds getting far more bigger than the original size, while primarily on the screen they were looking pretty innocuous to me. So it was almost double the size in 2 or 3 cases. After the initial debridement, it was almost double the size. And that's why I ask, apart from being healthy, bleeding margins and the muscles, like what exactly is the cause of that much increase in the size of the wound after debridement?
Yeah. Okay. Thank you for asking this question, because if there are any juniors, I would just explain this in a little bit of detail, because this is fundamental. Now, our capacity to reconstruct defects has enormously increased. Now, when you have the facility to transport bone, now it really doesn't matter whether it is 3 centimeters bone you're transporting or 6 centimeters bone you're transporting, or if it becomes 10 centimeters, you still have Ilizarov and other things which allows you to reconstruct, or you can do a microvascular free fibrillar graft. Similarly, when you have the facility to do a free flap, your capacity to reconstruct a soft tissue defect is up to 25 centimeters to 30 centimeters, which is very huge. Now, when you have that capacity, what is going to determine your success or failure? Now, if you have, let's consider 2 scenarios. You have a 5 centimeter wound, but deeply infected, compared to a 15 centimeter wound, which is very clean, which is easy to reconstruct, and which has got the highest rate of success. So, with your reconstructive capacity, the only single most important factor which is determining success or failure is the presence or absence of infection, isn't it? So if that is very well understood, then the whole concept of debridement changes. Now, previously the debridement was you tried to remove whichever you were thinking that is infected or necrosed. Now, the concept of debridement is you debride till you are sure that everything that is left is viable and non-infected. Now, both sound similar but are completely different. Now, the previous concept of debridement was you debride everything that you think is infected or necrosed. Doubtful. The idea was people said, okay, you leave a little bit of tendon looks necrosed and this thing, or there is a deep small bone is there, then you think this is good, so you leave it. The last 1 centimeter of the bone looks sclerosed and dead and infected, but you're still not wanting a bigger gap, so you leave it, and then you will suffer it for that decision. Because when the patient comes after 4 weeks, it is pouring pus or something, it is swollen, and you have burned the bridge of safe reconstruction. So now the current concept is you have to debride. You are sure whatever you have left behind is viable and bleeding. Now, it doesn't matter that a small wound has become a bigger wound. It doesn't matter. So instead of doing a latissimus dorsi flap, which was very small, 6 centimeters, you are going to do a 10 centimeter long latissimus dorsi. Rather than doing a gracilis flap, you may do a latissimus dorsi flap. But your chances of success will enormously increase. So you give benefit of doubt in doing more aggressive clearance. Size of the defect does not matter now. Your thoroughness of debridement actually matters. So as you become more and more experienced in debridement and reconstruction, you emphasize so much on debridement because your reconstruction options are now many and you are empowered by options. So that is why I think you have to make a larger wound, doesn't matter, but leave a.
Thank you very much, sir. Very nicely explained.
So, can we do delayed flap in the presence of infection? So, if you do a delayed flap, whatever reconstruction you do in the presence of infection. So, sorry, I think I have skipped some.
Sir, Dr. Asim Negi sir's question.
Yeah, I will go to Dr. Asim Negi. Many patients come after 24 hours. Do you use nail in these if it is nailable? The question of the sanctity of 6 hour mark. So when we were all students, they all said wounds less than 6 hours old you can do whatever, but more than 6 hours. Now this is no longer accepted because why the 6 hours was because they said contamination becomes an infection. Bacteria which is extracellular enters the tissue planes and becomes an intracellular or a tissue infection by about 6 to 8 hours. So that is why you will find when tissue wounds are coming before 6 hours, there will not be a secondary edema. But whenever you see a wound which is after 10 hours or 12 hours, many of these wounds will start developing marginal edema. Wound ends are looking slightly edematous. That means process of infection has started and contamination has become infection. So at that stage, when you do a reconstruction, you are begging for a more complication. So when you have, 24 hours, if you want to nail, then you must be sure that you are debriding this completely. If you can debride it thoroughly and if you can certify that this patient is without infection, if you are feeling very confident, then you can nail and then do a flap. So it is more important, we are not discussing about the number of hours, we are discussing about how clean the wound is. So that is not a big problem.
So interrupting in between, there's one question and the YouTube link as well. Can I go ahead with that?
Yeah, please, whatever it is.
There's a question from Dr. Rahul Verma from Bhopal. What's the protocol for converting X-fix to the internal fixation? Means whether it should be done immediately or should be done, wait for the pin track to heal.
Yeah. I mean, one of the, in some things which are going very well, you can feel your Waterloo if you don't manage this step very carefully. So the longer you keep your X-fix, the less carefully that you have maintained your pin tracks, then the chances are very high. Now, if you nail in the presence of one pin tract, doubtful pin tract infection, and then you get an infection, you're converting a small localized intramedullary infection into a pan-medullary infection. So you have to pay a lot of attention to it. On day one, when you put an external fixator, when you secure an external fixator, you must decide whether this is going to be a complete treatment or it needs to be changed. Now, if you know that this external fixator needs to be changed, then from day one itself, you must pay a lot of attention to the pin tracks and you must convert it to a definitive fixation as soon as possible. Wherever it is, we have crossed 4 weeks of external fixator, we give a window period, we remove the external fixator, secure it, put him on a slab and call him after 1 week to find out. Whenever there is no infection, you will find within a week, the pin tracks will cicatrize very well and close. If there is no closure of the pin tract by 1 week to 10 days, and there is still some doubtful granulation tissue, then you know that this limb is very risky to do an internal fixation. So you have to be very careful about that.
Thank you, sir.
So should tobacco be listed in the comorbid agenda? So smoking, I agree that excessive smoking should be on the comorbid agenda, 100%. So can we do delayed flap in the presence of infection? I think if you do a flap in the presence of infection, you are actually, see, when you have an open wound and it is infected, it is not so bad as to have a closed wound which is infected. The patient will get bacteremia, the patient will immediately get a swelling, the patient will get signs of inflammation, the patient will get fever, and they can get septicemia. So this is completely against the principles of surgery, that when you have an infection in a place, that you convert this open infected wound into a closed infected wound. So that will be inviting trouble. So if you have infection, you must debride once or twice and convert that wound into a clean wound, and then you can do a defect. And this is where the discussion, what we did even prior to the other question comes. So you have a 5 centimeter or a 6 centimeter infected wound. I mean, don't hesitate to do a wide debridement and convert it into a 10 centimeter clean wound. Because anyway, you are going to do a flap, so do a larger flap. And your success rate will be 10 times more when you do this rather than when you are hesitating to do a thorough debridement. So when decision of secondary amputation should be taken? I mean, that's a very long, it's a case-to-case decision that needs to be done. So I think the decision to secondarily amputate. What is the definition of a secondary amputation? If you are not amputated on your index procedure, when you debride and then you don't amputate and then you amputate afterwards, it's called secondary amputation. There are lots of people who say that you should still call it as a primary amputation if you decide to amputate within 72 hours. And this is something that we also follow. So if you take 100 of our amputations, then you will find that 80 to 85% of them are done on index procedure. So the other 15%, wherever there is doubtful, we extensively discuss with the patient, show them multiple photographs that have been taken during the primary debridement, tell them what are all the problems, and then we do a relook surgery in 48 hours, at which time we will definitely do a secondary amputation. If by any chance you have missed the bus and you find a florid infection in a patient whom you think leaving this wound and also doing multiple surgeries is very risky because of comorbidities or age, and then we do an amputation. So ideally, it is better to amputate within the first few days. So the next question is by Dr. Kumar. So should we fix the bone at one sitting and skin cover flap later so that at least pain of the patient is lowered?
In a badly contaminated fracture.
Yeah, so in a badly contaminated fracture, if you think that there is a risk of infection, you're not very sure of your debridement, then we would just fix the bone either by an external fixator, and we would not do a flap immediately. So that will be had a relook at 24 hours or 48 hours, and then we would do it. So there is a pain of the patient is lowered. I don't agree with that because we are now looking only at the risk of infection of doing this, the pain. The pain is not usual because now there are so many good methods of local blocks, regional blocks, and other things. You can do a huge procedure and then you can completely keep this patient pain-free. So after we have got this armamentarium of regional blocks, pain in limb surgery is no longer a problem. So that is not a big problem. So Dr. Gaurav Yadav, is there any consensus about antibiotic therapy according to the score? Okay. So the score does not address the issue of antibiotics, but I'm not sure what is your protocol. But in the last few years, we have undergone a big change in our protocol. So we did an antibiotic audit in the hospital, and we found a bulk of the patients who are consuming antibiotics were open injury patients. I mean, they actually were consuming so much of the antibiotics. And then we looked at it, and then we went into the world literature. Now I'm talking this about at least 10 years before. Then we had a major discussion, and then we made a willful decision that these patients will be treated like any other patients. So when they come, we would give them antibiotics for only 48 hours. So if this patient requires multiple surgeries, then we would treat them as multiple primary surgeries. So for example, the patient comes on day 1 with an open injury, then we would give him cefuroxime plus or minus amikacin only for 3 doses or 4 doses. And then we would stop antibiotics. Now this patient requires a free flap to be done after 5 days. Then that is taken as a primary surgery, and we would give whatever is the antibiotics that the plastic surgeons want to give for 3 doses and then stop. Now, after 2 weeks, if this patient requires corticotomy and bone transport, that is taken as a primary surgery, and then only antibiotics are given. Now, due to this, we have multiple advantages. Number one, enormous expenditure saving for the patient, but that is on the patient side. For our side, this is the best way you can identify an early infection. Now, if you do a massive debridement and you are putting him on piptas or magnus or linezolid for 1 week, now this actually suppresses the signs of infection. And then you are lured to thinking that, okay, you've got a reasonably good wound, and you do a free flap, and then you send him home. 3 weeks later, he will come back with infection. Now, if you have followed the principle of antibiotic of only 3 doses, now this patient, if he is not thoroughly debrided, after 4 days, he will start showing signs of infection. That means it is a clear indication that this patient is not ready for a free flap. You have to do one more debridement and make sure that everything is okay, and your chances of success of the soft tissue and bone reconstruction enormously increase. Our complication rates actually fell down quite a lot after we switched to this antibiotic protocol. So right now, this is our antibiotic protocol. In the last 10 years, we have cut down our antibiotic usage quite tremendously. So a very basic question. This is by Dr. Vikas Jain. He has said it's a very basic question, but after debridement, would you consider vac dressing or regular ones? Any specific guidelines? Okay. No, this is not a very basic question. It's a very important practical question. So use of vac in open injuries was for a long time limited to chronic injuries. Wherever there was chronic infection, wherever there was a chronic injury, failure of flaps, you didn't know what to do with these wounds for some time. So you put vac as a last resort. So this started as a last resort, but in some of the cases, the results were spectacularly good. And then we started looking at the whole world, actually. Started looking at what is the vac doing. And the vac is doing a lot of good to open injuries. So you should not apply vac in every single open injury after debridement, especially if it has still a lot of oozing and a lot of bleeding surfaces. You can drain 1 liter or 2 liters of your blood very easily in 24 hours. So you should be very careful. But in non-bleeding wounds, if your reconstruction is going to be over a long period of time, for some reason this patient cannot have a free flap for another 10 days, So in this period, an application of VAC is perfectly possible. So you can do that. Or in cases where you have no capacity to do, you're not equipped to do a big free flap, then you can apply the VAC and you will find that within 2 weeks, 50% of them are getting granulated very well. And then you can try other sources of soft tissue reconstruction. So over a period of last few years, our usage of VAC in acute stage wounds have also increased quite a lot. Not very much, but we use it from time to time. So is this core criteria also applicable for finger injuries? No. So it is applicable for upper limb injuries, but in finger injuries, you have different management principles. So that is completely different. So it is not applicable for finger injuries. It is not applicable for foot injuries. It is not applicable for hand injuries, but it is applicable for upper limb injuries and pediatric injuries, both with 1 kV. So upper limbs are more eminently, it allows us to reconstruct and salvage. So the cutoff for safe salvage in lower limbs, we said it is 14, but in upper limb, very frequently you can salvage up to 60 because the vascularity is very good, reconstruction options are very good, the union rate of both bones in the upper limb is very good. The defects are not very large, usually in the upper limb, and so you can use the score in the same way, but you give a leverage of 1 score or 1 or 2 scores to your benefit and the patient's benefit for salvage. So the next question by Dr. Vishal is using antibiotic-coated nails beads justified at the time of primary debridement when there are no signs of infection? Our utilization of antibiotic-coated nails, we don't have much experience. So, Dr. Asavadi and I, we keep frequently saying, fight infection with scalpel, which means that if you have a doubt, then we actually debride more, not with antibiotics. So if there is an infection, then whatever antibiotic if there is a necrosed tissue, if there is a contamination, then however much of antibiotic you do, you will always find that after 2 months, 3 months, they come back with a lot of infection. So if you are thinking that there is signs of infection or this thing, it's better to fight with this thing. But to make the answer short, our personal experience of using antibiotic-coated nails are actually nil, I would say. So Dr. Hassan Nagi to everyone, 3B intra-articular C3 type joint injuries, how do you approach bony reconstruction when they come on table after 48 hours, which is very common in secondary level, first treated at other place, then after? Actually, if you see, the principles are broadly the same. So if the patient has come after 2 or 3 days, then you have a very clear idea whether this is an infected wound or not. You stand to the advantage that you will know that whether this wound is already infected or not. Because 3 to 5 days or 48 hours, you know very clearly what is happening. Then your bony reconstruction is limited. Internal fixation is limited to articular reconstruction. So the screws and the wires or something that you require to reconstruct the articular surface is allowed. But then if you suspect that to be infected, then we would avoid an internal fixation. And for all other bony reconstructions, we would use an external fixator. Dr. Manoj, up to what score roughly you consider primary regular fixation like plating or nailing? Is there a cutoff score? No. So if there is a score of more than 10, where there is high energy violence. Now in these violence, we don't want to do reaming of the bone. So we would not do an interlocking nail wherever the total score is more than 10. But for any reason, you want the alignment to be maintained and you would like to have a plate fixation without stripping more of the periosteum. We don't mind putting in the plates if the soft tissue reconstruction is going to be very, very early. So when the score is very high, we don't do an immediate reaming of the bones. So Dr. Vivek Srivatsa, two questions. First is any role of sending culture on day one before debridement in open roadside? Okay, that's a good question. Then role of intramedullary fixation with TENS or endosnail in pediatric age group. Okay. Now, this first question is very important because what is the role of culture sensitivity and sending in tissues? So is a very big question that we have to answer. Now, very clearly, you can send a culture either from the casualty, that is before you start at the time of presentation, or you can send a culture from the debrided material in the operating theater, or you can send a culture after your debridement from whatever tissue you have decided to leave behind. Okay, so there are 3 different time periods you can send a culture. Clearly, there is no role for sending culture on day 1 before debridement. It has been proved to be a complete waste of time. As I told before, in your own institution, please look at what is the flora with which the wound has been infected in the last 100 cases of open injuries. I bet it is Pseudomonas, Klebsiella, E. coli, Staphylococcus. These 4 will occupy the highest amount of time. Now, in indoor, you go to every road and take a swab and then send it for culture. It will grow some weird organisms. It will grow springomonals, it will grow bifringens, this thing. It will grow some fungus, it will grow some nonsense, but it will never grow MRSA. It will never grow Pseudomonas aeruginosa. It may grow Pseudomonas stugeri, it may grow Pseudomonas vinjalis. All these are contaminants, but very rarely it will grow Pseudomonas aeruginosa. It will never grow E. coli. It will never grow Klebsiella. Now, this goes to prove 2 points. That when you take a culture and sensitivity on day before debridement, that is not representative of what it is going to infect. So there is no point in sending. So we have actually published on this also. And this was one of the theses of one of our DNB students nearly 20 years ago. So we did over a period of 9 months. Culture at the time of presentation in casualty, culture from the debrided material, and culture from the wound that is left. Whatever you have decided, you think everything is good, then you take a little bit of muscle and send it. Now, the correlation to the infected organism in the cases that got infected to the culture, what was grown from the debrided material, was not at all correlating. So there is no point in sending a culture on day 1 because it just gives you a wrong lead, and there is no point in that. So the role of intramedullary fixation with TENS and OS, in the pediatric age group, if the whole thing is after a good debridement, if you think that the wound is good, there is no problem of intramedullary fixation in the pediatric age group, and you think the best method of stabilization is TENS, you can go ahead. It is the equivalent of doing an interlocking nail in the adult. Okay, the last question I want to answer, I think that's not...
Yeah, the answers already, sir. So many questions. Thanks for your entire time. I would ask Dr. Any more questions from anyone?
It was really a good evening with you also, with you, sir. And I would like to extend my heartfelt thanks on behalf of AOSI for accepting our invitation in these tough times when Tamil Nadu is getting locked down. You were stuck in traffic somewhere, but then you at least made on time, and you gave enlightening us with a word of wisdom of yours and knowledge. And a special thanks to our chairperson Rawat sir and co-chairperson Pradeep Chaudhary sir, and especially the pharma company Cadila Pharma. And thanks.
Thanks to Akshay for coordinating with sir. Thank you, sir, because he was, to let you everyone know, Dr. Rajshekharan was busy on his work and his home front as well. He had some family get-togethers as well. So both things at the same time, still he could able to give us some time. That's really an honor for the entire Indore Orthopedic Association. Thank you, sir.
Thank you very much, and let me wish all of you a very, very safe period during this COVID. I think we also have to follow the pathway of safety in our day-to-day life. Quite frequently, we are coming across surgeons who have been vaccinated also getting into COVID.
Yeah,
I think this is the time to pause. And we never stopped work actually. During the whole of the Corona period last year, we were doing full-time work because many hospitals are closed, and some of the complicated cases we were getting in quite more than what we were doing. For example, spinal cord tumors and spinal tumors, we were doing twice more than what we were doing before because no other hospital was taking. So there is no need to reduce work, professional work, but you have to follow the pathway of complete safety. But then there is also a gift of time which God is giving to us, some amount of free time. So that also we should use it very carefully and also very usefully so that we don't become changed persons at the end of this Corona time. I'm really feeling worried for students who are all going through the Corona period because they all lost their ability to read. They have lost the ability to concentrate, sit down and read for a long period of time. They have lost their ability to be competitive, to be focused on preparation for exams. And so over a period of 2 years, if this goes on, we are going to have a bunch of people who are not able to concentrate or be competitive or focus. Every government, state government is now vying with each other to reduce the examination levels. For example, in Tamil Nadu, you don't need to write any exam, even 10th standard. School board exams, they just cancelled. CBSE has cancelled the school exams. And
same here, sir.
But if you consider exactly what's happening in China, China Z actually said at the time, during this period, we will focus on two things. Our manufacturing should not come down under any circumstance. And he said children's education should not come down. And in China, during this period, they have started 30,000 schools for children of the future, which means every child will not only read Chinese, but also English and one more foreign language. It could be French, Portuguese, or Spanish, or whatever it is, but they have to read this. And they are reading very advanced mathematics and advanced computer and advanced science. So he says that these children from these 30,000 schools will be the world leaders in 2030. They will be the most intelligent, most well-read, and most equipped children of the future. So China is looking at that, and they're using Corona times to become better. And in our country, education is just going to dogs. So, if all of us change ourselves for worse during this Corona period, if we become fat, if we become less hardworking, if we become different, then I don't know what's going to happen to our country. So, good luck to all of you, and I wish that you and your family all stay safe and also be very good. So, thank you very much for this opportunity.
Thank you, sir. We really give you a standing ovation.
Definitely,
thank you.
Thank you, sir.
My friends and a lot of
Thank you, sir.
And thank you very much for this.
Thank you, sir.
Really a great talk, sir. Thanks a lot.
Thank you very much. Thank you.